difficult time. And I would always say that there are four main components to end-of-life care. The first component is to be able to prognosticate and recognize the dying phase, to recognize what's happening to your patient, that things are going down. Second is when we recognize how things are, we should communicate that with the patient and with the family. And then thirdly is to provide good symptom management, especially in that last period. And finally, ethical decision making, because as clinicians, we need to be comfortable with the things that we do to a patient. We need to know the ethical principles that actually support and the foundation as to why these things that we do for patients at the end of life are acceptable and appropriate. So starting off with recognizing the dying phase, it's not very difficult. I think that everyone kind of knows, but sometimes I find it strange that I see patients who are looking like this, obviously looking like they're in a dying phase, and yet there are lots of CT scans or MRIs, they're still waiting for a PET scan to be done. So anyway, I'll just go through this. Often, as you know, patients actually who are deteriorating, they become extremely weak, lethargic, and they get progressively weak until they're bedbound. And I think if you're following up a patient, you would actually recognize this. They also get reducing cognition and consciousness. They get semi-conscious, confused, delirious, and then finally they become unresponsive. Their oral intake starts to decline. They may not be able to swallow their tablets. They can take sips of fluid, but they tend to choke very often on it. And then you may hear noisy breathing of secretions and a gurgling sound when they breathe. Changes in their respiratory patterns like Ching-Sook's breathing, apnea, and mandibular breathing actually occur. And then you have a drop in their vital signs towards the very late stage. Now, some research has been done to look at actually the median survival, looking at these signs. You can see when patients actually have that terminal secretion or that death rattle, that heralds about short days of survival, 2.5. And things like when the vital signs actually drop, and mandibular breathing, of course, that's within hours. Right? So hopefully we can recognize when patients are dying, and then if we recognize it, then we need to actually communicate that and communicate it very clearly with the family. And that's a very important part. Don't underestimate it, because if we, very often, we recognize that a patient may be dying, but then we don't say anything to the family, maybe we feel awkward about it. And then when the patient actually dies, it becomes such a shock to the family, and there's all kinds of funny grief reactions that we have to deal with later on. So avoidance of end-of-life issues and talking about prognosis, if we don't do this, if we avoid it, it leads to poorer family satisfaction and psychological morbidity, and sometimes if the lack of information on their prognosis can lead to inappropriate decision making, like things like CPR and intubation and things like that at the end of life. And so, if on the contrary, if they are aware of their prognosis and what's going on, it does lead to greater satisfaction and lower levels of depression. So I don't have the time to talk about the details of communication and how to communicate it. Hopefully you would practice this as you go along, and you may already know. But if you recognize that a patient is dying, ensure that the family recognizes it as well. Next would be symptom management. And some of the key principles in terms of end-of-life management would be, first and foremost, continuous symptom management. Very often patients may have things like pain, dyspnea, nausea in an earlier part, and as they reach the terminal phase, they become less responsive. Sometimes people say that, because they're not responsive now, they don't have pain anymore. Don't underestimate the fact that the pain is still there, and they should actually continue with their pain medications. We would have to assess things using non-verbal cues, because you can no longer communicate well with them, so looking at their facial expressions, their respiratory patterns and whatnot, and minimizing medications, using only drugs that are actually meant for comfort, and we should cease futile medications like things like aspirin and omeprazole, ACE inhibitors and things like that. And of course, as they can't swallow very well, then we need to find an alternative route, the oral route. And commonly in palliative care, we like to use the subcutaneous route because it's very simple to use. It's easier than an IV line. You just have to pinch up the skin, take your cannula, stick it in at a 45-degree angle, pull out the skillet, and that's it. And it is much gentler if you're giving a patient morphine or midazolam. It's gentler in onset, so you don't have sudden drops in blood pressure and things like that. So that's why we would recommend it. You can even use it for subcut drips or hydration. Now, the common physical symptoms that we would anticipate and need to treat at the end of life includes pain, dyspnea, nausea, vomiting, delirium and agitation, and respiratory secretions. But I'm not going to talk about the first three because I think they're dealt with elsewhere. And I'd like to focus on just delirium and agitation and respiratory secretions, which are also very common that happen. So I'm sure that many of you may be familiar with patients who are very sick and kind of in the terminal phase, and they kind of look like, they're getting on and off the bed. They get up and they don't know what they want, and then they lie down, and then they're trying to walk here, and they're pulling everything off. So that's actually that kind of restlessness. And hopefully how we manage this is not by kind of restraining them and tying them up, because at the end of life, that's not a very dignified way to be. So some of the common symptoms that you may see in patients would be a confused behavior, incoherent speech, and very typically, you would get this reversal of sleep pattern. And I think you would see that the family will tell you that, meracha the whole night, and then in the morning they're all sleeping, right? So that is an early kind of, that's a subtle sign that, delirium is already occurring. And they've got these non-purposeful movements and getting on and off bed. So in terms of delirium, of course, if you can, try and rule out some of the reversible causes, which can be due to things like sepsis, electrolyte imbalances, hypoglycemia, drugs can sometimes cause it. Constipation also can lead to delirium, and atypical seizures. But if there is no reversible cause, then the cause really is the fact that the patient is dying, and this is called terminal delirium. Now, it's important then to explain this to the family, because this is the point where patients, family get very anxious about things, and I would always explain to them that the fact is that the patient is dying and the brain function is slowly shutting down. So if the patient is very severely confused and delirious, we would use an antipsychotic. Commonly and very easily available is haloperidol, but you can also use things like olanzapine or risperidone. We would add a benzodiazepine like midazolam if the patient's very agitated and restless. So this is just some of the common dosages that we may use. Normally, that we recognize this as a sign of a patient dying, rather than to start panicking and think that this patient is having an acute coronary syndrome. We need to go and do some chest X-rays or do all kinds of other interventions because they're suddenly having acute pulmonary edema. It is again something which can be quite distressing for family members, because when they hear this sound, they often may think that the patient is drowning on their secretions, and so, but the truth is it's actually due to secretions that pool in the airways, and it is not, and it causes this noisy vibration as air passes through the airways, but it does not normally cause the patient distress, so it doesn't make the patient feel breathless. We would also explain to the family that suctioning will not relieve it, suctioning will not be helpful, and it, in fact, will cause more distress. And sometimes the danger is when you suction a patient at this point, you may cause a vagal response, and then the patient will go asystole while the nurse is suctioning the patient halfway, and it looks really bad for the whole situation, right? So what we would then do is we would try and dry up the secretions instead of suctioning. We would use something like an anticholinergic, and very simply and easily available is Buscopan, hydroxyl butyrbromide, 20 milligrams TDS or QID. Can be given subcutaneously as well, and as a continuous subcutaneous infusion of 60 to 240 milligrams over a 24-hour period. Now, finally, just end off with talking about ethical decision making. And some of the common ethical issues that occur at the end of life include things like withholding and withdrawing life-sustaining treatment, things like CPR, ventilation, artificial hydration, and nutrition. And then issues of sedation, using sedation at the end of life, and things like opioids. And then again, just about what is euthanasia and what is not euthanasia. So sometimes people may find themselves confused. Ultimately, I think that a lot of people sometimes struggle with, when they're handling patients at the end of life, they struggle with this concern that the management that they provide the patient with may actually hasten death, and if I did something like that, if I gave them some sedation, would that actually approximate to euthanasia? And so in the end, sometimes people are very reluctant to actually manage the symptoms that are very distressing to patients at the end of life. So I just talk about some of the ethical principles and issues. Withdrawing and withholding treatment, ethically speaking, there is no difference in the two actions. So if you withdraw something, it is no different from not starting it in the first place. And this is ethically acceptable if the treatment is futile, if it's not in the patient's best interest or if the patient refuses. The guiding principles are that of dignity, comfort, and the rights of a patient. So when it comes to things like artificial hydration and nutrition, we need to recognize that the inability for a patient to maintain their nutrition through the oral route in the setting of advanced cancer and their declining function is a marker of the dying process. And so evidence has shown that artificial hydration and nutrition does not in any way improve survival in the dying phase. And what would be more important then is to provide just good mouth care, keep it moist and clean, and that would be better palliation and better quality of life for the patient at that period, rather than lots of drips and NG tubes, which may actually cause more distress and also lead to aspiration. Use of palliative sedation at the end of life, and this is where the principle of double effect comes in very importantly to understand. And the principle of double effect states that where an action intended to have a good effect can achieve this effect only at the risk of producing a harmful effect, then this action is ethically permissible, provided it satisfies the following conditions. First, the action is good in itself. So if a patient is very distressed, I want to relieve that distress or relieve that pain or that restlessness, so the action is good. The intention is solely to produce the good effect. I only want to actually relieve the pain. I only want to relieve the restlessness. And the good effect is not achieved through a bad effect. I'm actually going to reduce the restlessness by using a sedative, and that is the FDA-approved indication for that drug. Right? And there is sufficient reason to permit the bad effect. We know we have diagnosed that the patient is dying. And we know that this patient has endured a lot of suffering, and if we don't actually do anything, then it's just a matter of more suffering until they finally die. And the ultimate point, thing is that they will still reach the same point. Right? So there is sufficient reason to permit the bad effect in case what we did actually did hasten the patient's or reduce the patient's survival. There is sufficient reason to permit it. So euthanasia, on the other hand, is defined as the intentional killing of a dependent human being for his or her alleged benefit upon their competent and voluntary request. Now the key word here is intentional, and the intent is to kill a person, and the successful outcome of euthanasia is for immediate death to occur. So if you were to use the argument of double effect for euthanasia, they may say that, yes, I'm trying to relieve the suffering, so that's a good effect, or well, that's a good intention. But the means in which they do it, the good effect is actually obtained through a bad effect, which is to cause death of the patient. And so that is why euthanasia and palliative sedation are not the same thing, and euthanasia can never use the principle of double effect to justify that. And so personally and also legally speaking in this country, this is not an acceptable practice. So the actions which are not, however,